or the collapse of the lungs. Now, if we're talking about the causes of the atelectasis, the causes of atelectasis, you have to remember there can be the obstructive cause, there can be the compressive cause. Either it can be due to some contraction or it can be due to some kind of the adhesive materials like we have the surfactant. So, if we're talking about the causes, the first cause we have that is the obstructive cause. Obstructive basically we will be having obstruction of what? Obstruction of the airways. So we will be having the airway obstruction can be there. Airway obstruction can be there. If airway will be obstructed, so it will prevent the air from reaching to the distal airways. Prevent air from reaching distal airway. Like example, for example, what can be the obstructive cause? It can be due to any foreign body. It can be any foreign body. It can be the any mucus plug can be there, or it can be any kind of the tumor that is obstructing the airways. It can be any tumor that is obstructing the airways. Okay, now see if you have some kind of the compression, the compressive. This is known as external compression on lungs. External compression on lungs. If you will be having some external compression on the lungs, so what it will do? It decrease the lung volume. So it will decrease what? Lungs volume. So due to which what will happen? It is the space occupying lesion and the pleural effusions. It is occurred due to any lesions that is occupying space occupying lesion and pleural space and the pleural effusion. What are the pleural effusions? Like for example, this is what we having the lungs. Let's suppose this is the lungs. Above the lungs we will be having the pleura. Okay. Now this pleura is made up of this pleura is what? That having the two layers. We have the outer layer, that is the parietal layer, and the innermost layer is what? That the visceral layer. Innermost layer, that is the visceral layer. Below this layer we will be having this space, and this space is filled with which fluid? That is the pleural fluid. The space is filled with the pleural fluid. Okay, the space is filled with the pleural fluid. Now, if there will be the loads of the pleural fluids will be, or the pleural fluids will be there in the pleural region, so that will cause the pleural effusion. Okay, so that's why what it will do, it will compress the lungs, and due to the compressing of the lungs, it will cause the collapse of the lungs. Okay, is that clear? After that, we will be having the third one, that is the contraction. The contraction, sometimes we call this as the cachectarization. Cachectarization. It is occurring due to like scarring of the lung parenchyma. Just remember, there is a scarring of the lung parenchyma. And this, it can occur, the contraction can occur due to sarcoidosis. It is occurred due to sarcoidosis. Okay, it distorts the alveoli. Because of the scarring of the lung parenchyma, it will distort the alveoli. That's why it will cause the collapse of the lungs or the collapse of the alveoli. Fourth is the adhesive cause. Adhesive here, you know, in the lungs, that is the surfactant. And the surfactant, it is due to lack of surfactant. Due to lack of surfactant, what you are going to see, there will be the adhesive. There will be the adhesive atelectasis. Now see, which cell produce the surfactant? We have the alveoli type 1 cell, or the alveocyte type 2. So which cell produce the surfactant?
Type 2, sir.
Type 2. So the type 2 alveocyte, they produce what? Surfactant. So you have to remember this one as well. Okay, see the spelling. Alveocytes. Type 2 alveocytes. Okay, so this is what that will produce the surfactant. So here we have discussed about what? This is the atelectasis, and in atelectasis we have discussed one other important disorder, that is the pleural effusion. Pleural effusion. What is the pleural effusion? I told that there is a fluid accumulation where in between the pleural layer. So what it will cause the lung compression. So this is basically what excessive accumulation of fluids between pleural layers. The excessive accumulation of the fluids between the pleural layer is known as the pleural effusion. So what it will do? It restricted the lung compression during inspiration. Okay. Now, if you're talking about the fluids, sometimes you come across the two fluids, exudate or the transudate. Okay. So let's clear it here. See, when we talk about the fluids, we talk about the exudate, we talk about the transudate. Now see, what is the exudate? The exudate, they are the cloudy fluids. They are like the cellular fluids. Means they are the, see, TR means transparent. TR means, you can understand here, TR you can remember, that is like the transparent. TR is equals to transparent. Transparent means clear. Transparent means clear. So transudates are the clear fluids. Or we can call this as the hypocellular. We can call this as the hypocellular. So transudate you can remember by the transparent. Transparent means clear. So that is why the transudates are the clear fluid. But if here we talk about the exudate, so exudate, remember, they are the cloudy fluid. Means they are the loads of the cellulars. Loads of the cellular. In exudate, you are going to see the loads of LDH will be very, very high. And in the transudate, remember, the LDH will be very, very low. Lactate dehydrogenase. So the cloudy fluids, why the exudate will occur? The exudate usually will see in due to infections, like we have the pneumonia, tuberculosis, CTD, trauma. That will cause what? Exudate due to infections. Due to infections like pneumonia and TB, CTD, or it can be due to trauma. The transudate, remember, it will be due to like heart failure. When the heart failure will be there, we'll see, can be seen that transudate will be there. Okay, and in heart failure, like in the heart failure where the sodium retention, so all this sodium retention can also cause what? Transudate. Because all these conditions, heart failure, sodium retention, what they will cause? They increase the hydrostatic pressures. They increase the hydrostatic pressures, and due to hydrostatic pressure, you are getting the hypocellular fluid. Okay. Along with that, decreased oncotic pressures can also cause what? Hypocellular conditions, like we will be having the nephrotic or the cirrhosis. Okay, in the nephrotic, what will be there? There is a large amount of the protein will be lost in the urine. So there will be the proteinuria, and that proteinuria where there is a decrease of albumin. If there is a decrease of albumin, there is a decrease of oncotic pressure. So the decrease of oncotic pressures, here also we can see transudate fluids. Okay, so this is the fluids that you should not forget. Now I think it's very clear. TR for transparent, transudate, TR transparent. So transparent means clear fluid. Clear fluid means low LDH. Everything will be low. Hypocellular, low cells. Exudate means LDH will be high. Cloudy fluids will be there. Cellular will be there. And exudate will be due to infections like the pneumonia, TB, CTD, trauma. Transudate due to some kind of the heart failure, sodium retention, nephrotic, or the cirrhosis will be there. For pleural effusion, remember, we use one criteria to diagnose it, that is the Light's criteria. That will not be asked in the exam, but that can be given in the question. That there is a Light's criteria suggest what? Light criteria suggest this. Light criteria suggests there's increased protein, increased LDH in the fluid. So that can be by the light's criteria. And light criteria is equals to protein fluid plural fluid protein divided by the serum protein, and second one is the plural fluid LDH divided by the serum LDH. Should I write it here or not? See the light criteria, just remember it is about the plural protein as well as divided by the serum protein, and that should be more than 0.5. And second criteria is includes that plural fluid LDH level divided by the serum LDH level. That should be more than 0.6. So just remember, for the pleural effusion, we will be having one criteria is there, that is the Light's criteria. And in the Light's criteria, it suggests there is increase of protein and increase of LDH level. Okay, so that's why there will be some exudate fluids will be there in the pleural effusion. So this is about the pleural effusion. We have the excessive accumulation of the fluid between the pleural layers. Now this, see, in pleural effusions, you can see the exudate as well as transudate as well. Like if the patient, there is heart failure patient, or if the patient due to sodium retention, they are getting some kind of the pleural effusion, so you will get the transudate in that. Okay. Okay, the next lung pathology that is very, very, very common, that is the pneumonia. Pneumonia. That is the pneumonia. See, what is the pneumonia? Basically, it is what? That is the some kind of the fever, or we can say that is some kind of a inflammation. Okay. So this is like infection that inflames air spaces. What are the air spaces? Alveoli. In one or both the lungs. That is what? That we have the pneumonia. Now for the pneumonia, we having subtypes. We have the lobar pneumonia, we have the bronchopneumonia, we have the interstitial pneumonia, we have the aspiration pneumonia. And these you have to remember. Let's discuss it one by one because all has been asked in your exam. So the first one we will be having, that is the lobar pneumonia. Lobar pneumonia, as the name is suggesting, the lobe will be affected. So that will involve the entire lobe, or it can involve the whole lung as well. There will be the intra-alveolar exudate consolidation. Consolidation is basically the radiologically term consolidation. When we say the inter or intra, I hope you are clear with the inter and intra. When I say the inter or intra, let's suppose this is what? You have the two boxes, and in one boxes you are sitting. In one boxes you are sitting, another boxes somebody is sitting. Okay, whatever, and in between you have the some space that is connected with each other. Okay, this is the space. So the space that is connected with each other is known as the inter. That is the inter. That is the inter. Okay. Now this one where you are sitting, this is known as the intra. The same like we have the intracellular or the intracellular. Okay. So the part, the space that is present between the two cells is known as the intercellular. The space that is present inside the cell is known as the intracellular. Okay. This is the intra. Okay. So we have the intra-alveolar, means it is inside the, you see the alveolar, you see the exudate, and due to that you see the consolidation, that is the lobar pneumonia. It involves what? Now you understand that this is the intra. Intra means inside the alveoli. Alveolar, inside the alveoli. Exudate, the exudate will be there. So exudate is what? Due to infection, we have the infections like the pneumonia. The consolidations means it will consolidate, it will collapse the lungs, or it will destroy the alveoli. So that's why it will become the intra-alveolar exudate consolidation. It involves the entire lobe, or it can involve the whole lung as well. And the most common cause for the lobar pneumonia is what? That is the Streptococcus pneumoniae. That is the Streptococcus pneumoniae. That is the Streptococcus pneumoniae. This is the most common cause. Okay. When we talk about the lobar pneumonia, remember, the lobar pneumonia have some stages will be there. It doesn't mean that it will the lobar pneumonia it will cause the entire lobe or the lungs. So it will cause the consolidation at single point. No, there are some stages are there. The first stage you will be having, that is the congestion. There will be the congestion. What is the congestion? Means whenever the congestion means that there is some fluids and bacteria are present. So there, where you will see the fluids and bacteria in the alveoli. So this is the congestion in alveoli. Fluids and bacteria in alveoli. That is the congestion of the alveoli at the first stage. After the congestion, what you are going to see the red hepatization. There is the red hepatization. Don't remember the stage, but you have to understand the thing what is occurring in the pneumonia, lobar pneumonia. Red hepatization means RBC. Red for RBC. So these alveoli will be filled with the at this stage alveoli filled with RBC, and there will be the fibrin material will be there. Fibrin or fibrin material will be there. After the red hepatization, there will be the gray hepatization. There will be the gray hepatization, and the gray hepatization basically means you have the breakdown of what RBC. We have the breakdown of RBC will be there. After the gray hepatization, what you are going to see? You are going to see the resolution. In the resolution, what you are going to see? There the cleaning of exudate will be there. There will be the cleaning of exudate. There is the cleaning of the exudate. So these are the some stages. Firstly, you see the congestion, then red hepatization, gray hepatization. After that, it will be resolution. Now you are going to see, of course, the pneumonia is there. You are going to see the some symptoms as well. Whenever you got the sometimes fever, high fever with the chills, what do you say? Pneumonia ho gaya. Pneumonia occurs to the baby. So there is high fever with the chill, high grade fever. High grade fevers with chills. Or with chills, we can say the rigor. That is chills or the rigor. Rigor is also means that is the chills. Along with that, you see the cough with sputum. And the sputum will be the rust colored because of the red hepatization, the gray hepatization. You see the rust colored sputum. When you do the diagnosis, on diagnosis, what you are going to see? You are hearing the sound. You see the crackles. You see the crackles. You see the diminished breath sound. Because this entire lobe is affected. That's why you will not hear the sound and diminished breath sound. And whenever you say that I didn't able to hear any sound or auscultation of the lungs, it means that this is not a normal sign. Usually what we see, usually in the normal condition, there is a bilateral air entry present. Means on the both sides there is the air entry present. So you will see the gust of air is coming and out. You will see here that sound on auscultation. But if you're not hearing any sound or there is a diminished breath sound, it means there's something is there. Something consolidation is there. Okay, so that is not a normal side. On the chest X-ray, what you are going to see, you see the lobar consolidation. Lobar consolidation. We will be having the second one, that is the bronchopneumonia. Bronchopneumonia. Bronchopneumonia is what? That is the patchy inflammation. Means that it is a patchy inflammation. That means there is a lots of patches will be there, and it affect what? Multiple areas. It is what? Patchy inflammation, and it affects what? Multiple areas. It affects the multiple areas. What are the multiple areas? Like where the bronchi and the alveoli. The bronchi and alveoli will be there. The bronchi and the alveoli will be there. This bronchopneumonia, remember, it usually what? Multifocal, and it will be the scattered. Usually multifocal and scattered. Okay, as the name is suggests, see bronchopneumonia, we have the effect the bronchus. Bronchus, it will the on the it having the multiple areas, so it will affect the either bronchi and the alveoli as well. Along with that, you see the patchy inflammations. Along with that, what you are going to see the patchy inflammation, and the common cause here that will be the Staph aureus or the Streptococcus pneumoniae. The cause you have to remember here, that is the Staph aureus and the Streptococcus pneumoniae. In this, you are not going to see the high grade fever. You are going to see, because of the patchy inflammation, not the whole lobe is affected. That's why you are going to see what kind of fever. You are going to see mild to moderate fever. Mild to moderate fever will be there. Mild to moderate fever will be there. Along with that, what you are going to see, you see the cough with the purulent sputum. You are going to see cough with purulent sputum. You are going to see cough with the purulent sputum will be there. Okay, so these are the symptoms that you are going to see in the bronchopneumonia patients. On physical examination, when you do the physical examination, what you are going to see? Physical examination, like you have to make the diagnosis. Here you can also write the physical examination diagnosis rather than physical examinations. Okay, physical examination or the local examination, when you are doing the local examination, what you have to do? You have to again, you will see the crackles, wheezing on auscultation. Wheezing on auscultation, and of course there will be the diminished sound. There will be the diminished sound will be there. On chest X-ray, what you are going to see? Chest X-ray, you are going to see there will be the patchy infiltrate in multiple lobes. There will be the patchy infiltrate in multiple lobes will be there. Okay, so this is what we are going to see on the chest X-ray. So this patchy, you have to, whenever the patchy inflammation, patchy things will be there, you have to remember about what? Bronchopneumonia. And of course, there will be the some inflammation or the consolidation will be there in the patchy form. Of course, there will be the crackles or the wheezing will be there on the auscultation, and along with that, you see the diminished sound on auscultation. After that, if you see the third one we will be having, that is pneumonia. Again, third one pneumonia, that is interstitial pneumonia. The interstitial pneumonia, or we can say this as the atypical. This is also known as the atypical pneumonia. The interstitial pneumonia or atypical pneumonia, when it comes, the first thing that should be coming in your mind is the mycoplasma. Along with that, you can also see there will be the chlamydophila. So these are the two organisms that causing what? Interstitial pneumonia. Okay. Now again, what is the interstitial? They have the interstitium, and between the space between the two tissues, that is the interstitium tissues, that the tissues that surrounding the alveoli. So if the pneumonia is affecting what? The pneumonia that affecting interstitial tissue. That is surround the alveoli. The surrounding of alveoli. That is what? Interstitial pneumonia. Okay. So due to that, if this interstitial tissue will be affected, so due to that, what will be there? There will be the inflammation. There will be the inflammation will be there, and due to that inflammation, there will be the scarring will be there. There will be the scarring will be there, and this scarring is known as the fibrosis. Scarring and inflammation, scarring of the lung parenchyma. Okay, so this is what that is interstitial pneumonia. We have the mycoplasma, chlamydophila. This pneumonia, in fact, in the interstitial tissue, as the name is saying interstitial, so it is affecting what interstitial tissue, and due to that, you will see the inflammation and the scarring, the fibrosis of the lung parenchyma will be there. Other cause, it can be the influenza, respiratory syncytial virus, cytomegalovirus can be there, pneumocystitis, GROSC can other cause. So the cause again you can write here. You can have the mycoplasma. We can be having the influenza, cytomegalovirus, respiratory syncytial virus, pneumocystitis GROSC. Pneumocystitis GROSC. Sometimes this interstitial pneumonia is also known as the walking pneumonia. This is also known as the walking pneumonia. Walking pneumonia. And what you are going to see here, along with that, when you do the chest X-ray, to the chest X-ray, what you are going to see, you see the multifocal bilateral opacities. Bilateral multifocal opacities will be seen. Okay. After that, there is one more pneumonia is there, that is known as the aspiration pneumonia. That is known as the aspiration. And of course, this pneumonia, you understand it by the name, that is the aspiration. If something is aspirating. Okay, so what can be aspirated? Like if the patient is bedridden patient and having some kind of the surgery. So what can be there in this patient? There is high chances of the aspiration. For the patient having the seizures, they have the high chances of the aspiration. What they will aspirate? They will aspirate their oropharyngeal or the gastric content. So the aspiration of oropharyngeal or gastric content into pulmonary. Okay, in that respiratory tract. So into respiratory tract. That will lead to the infections. So if the aspiration of oropharyngeal or the gastric content into the pulmonary or the respiratory tract, then it will lead to the infection. Of course, if any whenever do the anesthesia also, the anesthesia time, there is a high chances of the aspiration of any oropharyngeal or gastric content into the respiratory tract. And that's why we say to the patients that NPO, nil per oral, till from before 6 hours, before 8 hours, according to the surgery, nil per oral, or that's why we say na, so that it should not aspirate any oropharyngeal or gastric content into the respiratory tract. Okay, is that clear till now, anyone? Hello.
Yeah, doctor.
Okay, so this is basically we have the aspiration pneumonia. Now we will be having the risk factor here in this situation, that is the, as I told you, that in the patient with the having the neurology patient, okay, and having some kind of the altered mental status, or we can be having the cuff reflex or the glottic closure. They all can cause what? Having the aspiration pneumonia. The patient with the dysphagia, the patient with the just I told you, the neurological disorders like the stroke, neurological disorder, the patients with the stroke, seizures. Then we can be having the invasive tube as well. The invasive tube, that is also known as the nasogastric tube. that can also cause what? Aspiration pneumonia. Aspiration pneumonia, it is more common in right lower lobe and more common in right upper lobe. When we say about the right, because on the right side we're having the more space, more you can say more dilated bronchi, you can say, and the right lower lobe and the right when it will be the more common in the right lower lobe when the patient in sitting position, if sitting up. So in the sitting up, it will go to the, due to gravity, it will go to the right lower lobe. And if he is in the lying down position, then it will be on the more common in the right upper lobe. Okay. And this aspiration pneumonia have some complication. It can progress to the lung abscess. It can progress to lung abscess. Okay. So this is basically we have the aspiration. That is aspiration pneumonia. Okay. In simple words, if you want to understand about the aspiration means like breathing of any foreign objects. Breathing in the foreign objects or breathing of any foreign objects will be called the aspiration pneumonia. Any gastric content, oropharyngeal, that can be, we can say any material, any foreign object from the outside into the trachea, that can also cause the aspiration pneumonia. Or this patient with having abnormal swallowing problems, abnormal disorders, they have the more risk factors to the aspiration pneumonia. Now they have the complication. The complication is what? That is the complications we have, that is the lung abscess. Lung abscess. When we see the abscess is basically that is a pus, and if it is a localized, then it will become abscess. Localized collection of pus within lung parenchyma. Within lung parenchyma. Localized collection of pus within the lung parenchyma, that is known as our lung abscess. That is known as the lung abscess. This is basically the pus, but if it is localized, then we call this as the abscess. And just we have to understand this is caused by the complication of the aspiration pneumonia. So this is basically caused by the aspiration of oropharyngeal or the gastric content. Oropharyngeal or the gastric content. On chest X-ray, you are going to see air fluid level. Air fluid level will be seen. Air fluid level will be like, for example, if this is the lungs. So in the lungs, we will be having the air will be due to gravity, it will come upside, and there will be the fluids or the abscess or the pus that will be settled down due to gravity. So that's why this is the pus, this is the air. So that's why it will gives like the air fluid level on the chest X-ray. Okay, there is just something also called the, if you are talking about the air on the lungs, the air in the lungs. The air in the lungs is another terminology. That is we call the pneumothorax. That is called the pneumothorax. Okay, ये बहुत ज़्यादा हो गया. So let's revise it fastly so that you will understand. Okay, so what we have discussed in the pneumonia, we have seen that there is a pneumonia, that is infection that inflame the that air spaces. Or view in the simple words, if you say the pneumonia, that is means inflammation of the alveoli. And now this pneumonia is categorized into the different types. Whether lobar pneumonia, if it is involving the whole lobe, that is the lobar pneumonia. The most common cause is the streptococcus pneumonia. And if it is involving the whole lobe, there will be more stages will be there, more things will be there. Firstly, it will be the fluids and the bacteria. After that, the RBC will come. Now there is a breakdown of RBC, and after that, cleaning of alveolate will be there. Now symptoms, as this is involving the complete lobe, so you can remember it like that. There will be the Symptoms will also be high. So high grade fever will be there. Along with the chills, rigor will be there. Cough with the sputum. This is a rust colored sputum will be there. And there will be the complete lobe consolidate. So that's why the diminished breath sound will be there. And the chest x-ray, you see the lobar consolidation. Bronchopneumonia, you see the patchy inflammations. It affects the multiple areas. So multiple area means some patches will be there. Like if you take out some paint on the paint in the bruise and you put them on the wall, so it will be looks like everything will be the patchy color. So it will be like patchy inflammations and usually multifocal because involving the different lobes. It can involve the bronchi, it will involve the upper lobe, it will involve the lower lobes. So that's why it is the multifocals, having the different location will be there and the scattered will be there. The cause here is the Staph aureus and there will be the Streptococcus pneumonia. The symptoms that are mild to moderate, cough with the purulent sputum. Physical examination will be the same. Chest x-ray will be the patchy infiltrate in the multiple lobes. Then we have the next one, that is interstitial pneumonia. The interstitial pneumonia is saying atypical. Atypical, the mycoplasma or the chlamydophilia, or we are having the inflammations or inflammation is affecting the interstitial tissue. This is also known as the walking pneumonia. So the walking pneumonia, the question they will ask you the walking pneumonia. Then remember what is the cause? Mycoplasma. Walking pneumonia, mycoplasma. Walking pneumonia, mycoplasma. Aspiration pneumonia, aspiration of oropharyngeal or the gastric content into the respiratory tract. Like we will be having, it can progress to the lung abscess, altered mental status, dysphagia, neurological disorders like the stroke, or we have the invasive tube like the nasogastric tube, more common in the right lower lobe or the right upper lobe. Then we have the lung abscess, that is localized collection of the pus within the lung parenchyma. Then we will be discussing about the pneumothorax. Okay, is that clear till here, everybody? Air on chest x-ray will be looks like black. And water or any fluid will be looks like white. Fluid will be white. Okay. Pneumothorax. If you say accumulation of air, this air in the lungs, but mainly if you say accumulation of air in pleural space. Accumulation of air in the pleural space, this is known as what? Or pneumothorax. Okay, what will be there? If there will be the air in the lungs, what will happen? There will be the dyspnea, the abnormal breathing will be there. Along with that, uneven chest expansion. Uneven chest expansion will be there. The patient will be having the chest pain. Hyperresonance. Hyperresonance means more blackish. That we call the hyperresonance. Then it will be the diminished breath sound. Because of the air, it will give the diminished breath sound. Okay. Now see, this pneumothorax, it can be the primary, or we call this as the spontaneous. Primary spontaneous, or the second, it can be the secondary spontaneous, or it can be the traumatic, it can be the tension pneumothorax. The first one we having, that is the primary spontaneous pneumothorax. All these are of your question. I am not telling anything extra. Okay, primary spontaneous pneumothorax. If you're talking about the primary spontaneous pneumothorax, it is occurred due to rupture of any subpleural cyst. If are made, a cyst means like some air-filled space, air-filled cavity. So that's why if that is rupture, due to rupture of subpleural cyst or bleb. देखो, why we call this as the primary? Primary means origin or the location will be related to that region only. Here we are talking about the lungs. So in the lungs we have the pleural lungs, we have pleura, we have the subpleural. So in the subpleura, if you are getting any cyst are there, that means it will be the primary cause. If it is occurring due to, if this pneumothorax is occurring due to any particular disorder other than the lungs, then it will be the secondary cause. So the cyst here, you can remember, it is the air-filled cavity. Cyst is basically air-filled cavity. And this associated with the tobacco or the smoking. It is associated with the tobacco or smoking. And is more common in the tall, thin, young people. Tall, thin, young males. Then we will be having the secondary cause, the secondary spontaneous. Secondary spontaneous pneumothorax. देखो secondary spontaneous pneumothorax is due to disease of the lungs. Due to disease of the lungs. Okay, जैसे for example we have the bullae in emphysema. Bullae in emphysema. If that will rupture, that will cause the secondary spontaneous. Marfan syndrome also. And any other infections. Any other infections that will be causing the spontaneous pneumothorax. After that, we will be having the third one, that is the traumatic. The traumatic basically means due to some trauma. The traumatic pneumothorax because of some trauma. Like for example, if there any road traffic accident, or if any RTA are there, and due to RTA, there will be the some rib fracture are there. There can be the rib fracture, and this rib fractures will lead out. We call this as the blunt trauma. If the rib fracture will be there, of course there will be the lots of air will be coming inside, and that will cause the pneumothorax. If we will be having the gunshot. If you will be having the gunshot, and gunshot, you know that is the penetrating trauma. Penetrating trauma. And if this will penetrate, this will be the penetrating the air as well, along with the gun, along with the gunshot. So there will be some penetrating air. So that will penetrating the trauma as well, and the penetrating the air that will cause the pneumothorax, or that the penetrating pneumothorax. Okay, and then it can be the some iatrogenic cause. Iatrogenic basically, can you tell what is the iatrogenic?
आफ्टर सर डॉक्टरों की कमी की वजह से भाई.
ठीक है, due to any mistakes by the any medical, not just doctor, ठीक है, by any medical staff. ठीक है, basically it is by the doctor, but any medical staff can be there, so like any nurse or they due to iatrogenics. So okay, a healthcare worker basically. We others like for example central line placement. Central line placements. Then we have the lung biopsy. So during the lung biopsy, it can injure what? The lungs, or it can be by the barotrauma. Okay, by the trauma of the like anithorax region. So central line placement, lungs biopsy, barotrauma, there are some or iatrogenic cause. So they will cause what? Traumatic pneumothorax. Then there is another one, that is a tension. Lots of tension. I don't like tension, but tensions likes me. Tension pneumothorax. देखो, tension pneumothorax, when we say tension pneumothorax, what is the cause? The cause can be any of the above conditions that we have discussed. It can be the tobacco, smoking, rib fracture, gunshot, iatrogenic, any cause can be there that can cause the tension pneumothorax. Okay. Basically, what in the tension? That whenever the tension occurs in us, the tension occur in us when the exams came, lots of the things comes in our mind, but those things never go out, and those things create tension in us, right? So that is again same with the pneumothorax. When the air will enter the pleural space, but it cannot exit, that will create the tension. Can be any above condition. Okay, Then remember that it is tension basically enters, air enter the pleural space but can't cannot exit. It will be trapped. So the increasing of what trapped air. This will be the increasing of what trapped air. That will create what tension. So this increased trapped air, what it will do, it deviates what trachea. It deviates trachea away from affected lungs. Away from affected lung. This is very important because sometimes they will give you the tracheal deviation and in the question they will write tracheal deviations to the opposite side. So tracheal deviation from the away from the affected lung means opposite from the affected lungs. There, if the tension will be there, it will increase the pressure. So there will be the increase of intrathoracic pressure. Increase of intrathoracic pressure. And you know that between the thorax we will be having some mediastinal space. So if for intrathoracic pressure will be there, so there it will cause the mediastinal displacement. It will cause the mediastinal displacement. It will cause the mediastinal displacement. Increased trapped air, it can be due to it will cause what? It can cause obstructive shock due to increasing of the trapped air. The obstructive shock can be there, and the shock. Remember, whenever the shock things comes in your mind, there the two things will happen. The first, there is the decrease of heart rate or increasing of what? उल्टा लिख दिया. Decrease of blood pressure and increase of the heart rate. The heart rate will be increased and the BP will be fall down. It means the patients can go into the shock. It can be the any kind of the shock. It can be our anaphylactic shock. It can be the septic shock. It can be obstructive shock. Any shock will be there. But there are two things like the decrease of the blood pressure, and due to that decreasing of the blood pressure, the heart rate will be shoot up or that it will be increased. And it can also cause what? Jugular venous distension. JVP findings will be there. Jugular venous distension. Okay, so these 2 points you have to remember. These 2 points will be coming in the question itself, not commonly asked. And if you getting the tension pneumothorax, so of course it is the emergency condition. Okay, you can't treat by the just conservative or the medical management. You have to treat them by emergency. You treat them in emergency. What emergency take up you will take? So in the emergency, you will take the immediate needle thorax decompressions. So this is the emergency situation. So emergency, what you do? You will take a needle, you will do the decompression, immediate needle decompression. Immediate needle decompressions. Means air, you have to make the air out. Okay. And along with that, you to place a tube, that is the chest tube placement. Chest tube placement will be there. Okay, so this is what basically we have the pneumothorax, in which you have discussed about the traumatic, primary, secondary, and the tension pneumothorax. Okay. After that, we will be having the second one, that is the hemothorax. Now see, hemo means blood. So if you are having the blood in the lungs, blood accumulated in the pleural space. Blood accumulated in the pleural space. So that is the hemothorax. And we have the hydrothorax. Hydrothorax. Then if it is the fluid accumulated in the pleural space. Now see, it sometimes it can be the pneumohydrothorax, pneumohemothorax. So you will see here air fluid level. You will see here the air fluid levels. So basically air plus fluid both will be present. Both will be purging. So air due to gravity it will come up, and the fluids due to gravity it will settle down. So it will give the air fluid space, air fluid level. ठीक है? Is this clear? Okay, yeah. After that, in the questions, you will get sometimes resonance. You will get the hyper resonance or the hypo resonance. Okay, make a table. Write the digit pleural effusion. So in the pleural effusion, what you will see, the pleural effusion, you see the on the percussion, you will see the dull percussions, dull sound on percussion. Along with that, if you see, you have to see there is a percussion, you see the tracheal deviation, you see there is a sound. So firstly, you see the percussion on there is the dull and there is a no tracheal deviation. There is no tracheal deviation will be there. No tracheal deviation will be there on pleural effusion. After that, the second one we will be having that the atelectasis. Atelectasis. The atelectasis basically we have the dull sound on percussions. We are having the dull sound on percussion. And along with that, you see the trachea will be deviate. Trachea deviates towards the side of the lesion. On the same side, towards the same side of the lesion. Towards the same side of lesion. Okay, that is what we have the atelectasis. That we have the atelectasis. The third one we will be having, that is the simple pneumothorax. The third one we will be having, that is the simple pneumothorax. Simple pneumothorax. Simple pneumothorax, you will see the hyper resonance sound. What you are going to see? Hyper resonance sound on percussion. Hyper resonance sound on percussion, and there will be the no tracheal deviation. No tracheal deviation. After, if you see that along with the simple pneumothorax, you know that is the tension pneumothorax, and the tension pneumothorax, you have seen that there will be the tracheal deviation where on the opposite side. Okay, so what you are going to see here, the sound will be the same. There is a hyper resonant sound because of the air. Hyper resonant sound on percussion, and tracheal deviation away from the side of lesion. Tracheal deviation away from side of lesion. Okay, now you can easily differentiate atelectasis and the tension pneumothorax. In atelectasis, this is towards the same side of the lesion. So you have to remember in the tracheal, you have to remember away from the side of lesions. Okay, in tracheal, you have to remember this will be the away from side of lesion. Away from the side of lesion. Okay, there is a one more thing, that is the consolidated or the lobar pneumonia. Consolidation, basically we will be having the lobar pneumonia, or in consolidation can also be seen in the pulmonary edema as well. In pulmonary edema. Okay, so the consolidation, what you are going to see, You are going to see the bronchial breath sound. Bronchial breath sound. Late inspiratory crackles. This is a very important point. Late inspiratory crackle sound will be here. Dull sound on percussion. This bronchial breath sound you will be heard on the auscultation. Dull sound you will hear on percussion. Along with that, you see the no tracheal deviation. If consolidation are there, no tracheal deviation will be there. No tracheal deviation. Okay. Is that clear? Now you are seeing the hyperresonance, hyperresonance. So one thing you have to remember that if the resonance things comes in question, resonance basically means hollow sound. Resonance means hollow sound will be there. So resonance we have the hollow sounds. So hollow sounds we will be having like if it is the increasing is basically means now if this hyper resonance we are seeing, that means there is a reduced what? The reduced lung tissue density. Reduced lung tissue density. It is occurring in the pneumothorax. It is occurring in the pneumothorax and it is occurring in the emphysema. Emphysema are what? They are known as the hyperinflated lungs. Hyperinflated lungs. Okay. So this is there will be the reduced lung tissue density will be there. And there will be the decrease. Decrease is basically hyporesonance. Decrease hollow sound. When the hollow sounds will be decreased at the dullness. Or we call this as the dull sounds. Dullness sounds. Dullness. Dullness basically will be seen in pleural effusion. Consolidation. Hydro and hemothorax. Okay, is that clear? So this is basically we have the resonance. Resonance with the hollow sound, increase or decrease. Decrease we have the hyperresonance. Increase we have the hyperresonance that is in emphysema and the pleural pneumothorax. And decrease we have the hyporesonance that is seen in the pleural effusion, consolidation and the hemothorax. Hyporesonance basically we have the less air, dense tissue, softer and dull. Okay, or hyper you can remember is that we have the reduced lung tissue density, along with that excess of the air. Okay, so now you will not able to miss any of the question. Okay, everything is clear till now. Having here a 39-year-old child hospitalized at hospital with acute glomerulonephritis. So in the acute glomerulonephritis, what you are going to see, there will be the proteinuria. There will be the decrease of the salt, decrease of the free diets, and decrease of the fat. Okay, what must not be limited, that is what during the acute period will be the carbohydrate. Question number 34. The 34 is saying that a 18-month-old child hospitalized on the 4th day of the disease. The disease being acutely with a temperature 39 degrees Celsius. There is a weakness is there, cough, breathlessness is there, cyanotic febrile temperature for over 3 days. There are crepitative fine bubbling rails on auscultation. There is fine crepitative fine bubbling rails. Percussion sound is shortened. There is a diminished sound. That is the diminished sound in the right interscapular regions. So basically, if the diminished sound, basically you have the pneumonia. Or the X-ray picture shows non-homogeneous segment infiltration. What is the X-ray? What is non-homogeneous segment infiltration? 8 to 10 mm on the right. The intensification of the lung pattern. So this is basically we have the This is the segmental. So where we, this is if this is not the segment, then we can say that this is the case of the lobar pneumonia. And in the lobar pneumonia, you can see the high grade fever, weakness is there, crepitative fine bubbling results are there. But in this question, they have mentioned the segment. So that's why they have wrote it the segmentary pneumonia. And here you can see there is a homogeneous segment infiltration 8 to 10 mm, and that is what consolidation. That is what the consolidations. And each lung will having each lung, how many segments are present in each lungs? There is a 10 segments will be there. Each lungs having the 10 segments. The next option is bronchiolitis. The bronchiolitis occurring in the less than 3-month-old child. The interstitial pneumonia we have discussed. Then the grippy is called, this is what basically the language problem, that is the influenza. And we have the bronchitis. Okay. The next question we will be having. A 9-year-old girl has an attack of abdominal pain. This is a 9-year abdominal pain is there after the fried food. So after fried food, first thing comes in your mind, that is the something related to the liver. Hai na? No fever. There is a no fever. She has pain in the sera point. Sera is basically we know that is the Cares point. The sera is what? It is basically known as the Cares point. Or we call this as the Care sign. In the Care sign, the pain will be referred to, the pain will refer to shoulder. The pain will refer to shoulder. That is the Care sign. The liver is not enlarged. Portion B, duodenal probe is 50 ml. What is your diagnosis? So here you can see 3 things. The 9-year-old girl, fried food, sera point, Cares point. The liver is not enlarged. So, and the portion P, duodenal probe. The duodenum we will be having the, which one will the ampulla of Vater, where we will be having the common bile duct will be open. So what is your diagnosis? So this is basically we will be having the some motility disorders that will seen in this patient. And if you see, see here, when we talk about the abdomen, we will be having the 4 quadrants are there. 4 quadrants. This is the right upper quadrant. This is the left upper quadrant. This is the right lower quadrant, and this is the left lower quadrant. Are you clear about that? ठीक है यहाँ तक? ठीक है? You know about the all the 9 abdominal regions. We having the right hypogastric, left hypogastrics. Then we have the epigastric regions, right lumbar regions, umbilical regions, left lumbar regions. With the right iliac regions, hypogastric regions, and we have the left iliac regions. Okay, these are the 9 abdominal regions that you should know. So this patient is having what kind of the fried foods? They have the sera point. The sera point will be the Care points, and the sera point you have to remember this is the that will be present on the side of the liver. That is the basically. And when you see the pain will referring to the shoulder, then this is what suggesting us about some kind of the biliary disorder. Okay. And if you see there is some constant pain are there, where the patient is having some kind of the constant pain, then this is the sign of hypotonic, or we will be having this is known as the hypokinetic. And if we will be having some colicky pain are there, then this is what hypertonic or hyperkinetic. Hypertonic or hyperkinetic. Okay, they have not mentioned here the what kind of the pain, so you will consider it as the constant pain, because after the fried food they will be having the pain, so it means it will be the constant. If that will be the colicky pain, they will mention about the colicky pain, and is the pain in the sera point liver portion B is on. So this is basically it related to the biliary tract, and we call this as the which type? Hypotonic type. If it will be the colicky pain, then it will be the hypertonic type. The hepatocirrhosis, the liver cirrhosis, it is mainly due to in case of the alcohol conditions. The chronic duodenum, there is nothing like chronic duodenum. The peptic ulcers, that is by the Helicobacter pylori. Acute colitis means there is a pain in the, there is basically that there is acute pain will be there in the gallbladder or in the cholecystitis can be there. Question 36, a baby was born at the 36th week of gestation. Delivery was normal by the natural way. The baby has a large cephalohematoma. That is again what? That is the normal condition. The result of the blood counts are HB 120 gram. HB are 120 gram, basically 112 milligram. Erythrocyte is 3.5. Total serum bilirubin is 123. Direct bilirubin is 11. Indirect is 112. Now see, you don't know what is the normal value of the bilirubin. I also don't know. Okay, but here I can see the total serum bilirubin is 123. Bilirubin total is 123. The direct bilirubin is 11. Indirect bilirubin is 112. It means this is very, very high. This is means this will be very, very high. Okay. So the indirect bilirubin is very, very high. So what will be there? That will be the case of the indirect Okay, so see here. Okay, just a second. Okay. So basically, what we will be having, what in the like we are having the RBC. Now this when the RBC will be breakdown, this RBC breakdown into the heme, and this heme will be breakdown into the biliverdin. And in the presence of the enzyme, that is the biliverdin reductase, it will be converting into the bilirubin. Okay, now this bilirubin is here, that is the indirect bilirubin, or that we call the non-conjugated bilirubins. Now when for these conjugations, it will go to the liver, and the liver we have the enzyme that is the UDPGT, uridyl phosphate gluconyl transferase. UDP, uridyl phosphate gluconyl transferase. So this bilirubin, indirect bilirubin, will be converting into the direct bilirubin. In the presence of enzyme UDPGT, that is uridyl phosphate gluconyl transferase. So this enzyme, direct bilirubin, is the conjugated bilirubin. This is the conjugated bilirubin. Now this is what we have the liver. So liver we having, this is known as the hepatic conditions. I think we had discussed this in class. Huh? See, we are having what phenylketonuria. Usually what you are going to see, the phenylalanine will be breakdown into the tyrosine. Phenylalanine is what we have the TV till 9 p.m. So P is here phenylalanine, that is what essential amino acid. And this phenylalanine will be converting into the tyrosine in the presence of the phenylalanine hydroxylase. So this is the pH. Now this, when the tyrosine will be there, so this tyrosine will converting into the word form melanin. Okay. Now let's, in case of phenylketonuria, this enzyme will be deficient. This will be the deficiency of phenylalanine hydroxylase. And if this enzyme will be deficient, so there will be this tyrosine will become essential amino acid. At that time of in phenylketonuria, the tyrosine will become essential. The clinical feature that you have to remember in the phenylketonuria, that there will be the mental retardation. There will be the mental retardation will be there. there will be the mental retardation. Along with that, what you are going to see, as there will be the tyrosine, it will become essential compound. Tyrosine will become essential. Tyrosine will become essential compound at that time. Okay, what other findings you are going to see in this condition? The mental retardation we don't see in the alkaptonuria. Alkaptonuria is also the similar disorders, but that is the most common thing that you are not going to see. Then along with that, you are going to see the patient will be having some seizures will be there. The seizures will be there. And on the urine, what you are going to see, there will be the mousy odor urine. Mousy odor urine. For this, you do the one test, that is the ferric chloride test. You do the FeCl3 test, will be done. The next one is alkaptonuria. The alkaptonuria, you see some kind of the black cartilage. Black cartilage. Or we call this ochronosis. Ochronosis. Okay. Other than that, what you're going to see, there is no mental retardation will be there. No mental retardation. Okay, everything will be the black cartilage, black ochronosis, and the black pigments will be there. All these things will be seen in the alkaptonuria. The alkaptonuria is again the same disorders, but here we will see the phenylalanine. Then we see the tyrosine. Then we see the 5-hydroxyphenylpyruvic acid. Then it will converting into homogentisic acid. Okay, and this homogentisic acid will be converting into the MAA. MAA means that is the mallyl acetoacetic acid. And here you will see there will be some deficiency of one enzyme, that is homogentisic acid dioxygenase. So this enzyme will be deficient. So if this enzyme will be deficient, there is the increase of the homogentisic acid, and that will be accumulated in the cartilage, and that will give the black cartilage, ochronosis, and the black pigments. But there will be no mental retardations will be there. Okay, this is the main thing that you have to remember. And there's the black cartilage. Along with that, you see the black urine as well. Black urine due to oxidation of this homogentisic acid, that will cause the black urine. Okay, the phenylketonuria, you see there is a mousy odor urine will be there.